Hi, my name is Mike, and I'm going to present an adult musculoskeletal complaint. Patient's ID, initials DA, date of birth 8/23/69. He's a 55-year-old Caucasian male presenting to the clinic by himself and appears to be a reliable historian. Chief complaint states, I'm here today because I have been having neck pain with a stabbing feeling that goes down my shoulder and arm for about 2 weeks now. So HPI, 55-year-old male, has got an extensive known medical history, who's presenting today with right-sided neck pain times 2 weeks, radiating to his shoulder with an occasional shooting pain down his arm. Patient states his current pain is an 8 out of 10 on a 10-point scale. Patient states that the shooting pains are getting worse and it's keeping him up at night. He states that he has been taking ibuprofen, which has not been working for him. He denies any specific known injury that caused his chief complaint today. Patient denies any numbness, tingling, or weakness in the upper extremities with the exception of pain. No history of fever, chills, weight loss, or changes in appetite. No history of any headaches, dizziness, or visual disturbances. No complaints of chest pain, palpitations, or shortness of breath. PMH is benign prostatic hyperplasia, epilepsy, exercise-induced asthma, hypertension, osteoarthritis, prostate cancer, stroke, bilateral tendinitis, and anxiety. He has a 3 surgical history of a colonoscopy, biliary lithotripsy, and a recent TERP in 2022. Patient denies any known drug allergies, seasonal allergies, or environmental allergies. Medications, patient takes a list: Keppra, pregabalin, montelukast, lacosamide, prazosin, amlodipine, eslicarbazepine, lorazepam, PRN, lisinopril daily, Flomax daily, and an albuterol inhaler, along with OTC ibuprofen. Vaccinations all up to date from childhood. Last flu shot 2024 in November. Social history, patient denies any tobacco use or vaping. Also denies any or states an occasional use of 2 to 3 times per month with alcohol, and denies any substance abuse. Family history reveals father deceased at 84, had a history of diabetes mellitus along with prostate cancer. Mother, breast cancer, still alive at 82. Grandfather and grandmother, both heart disease, both deceased. Constitutional review of systems for subjective. Patient denies any weight changes, weakness, fatigue, or fever. Patient states tight lower occipital region feeling, however denies headache, dizziness, or lightheadedness, blurred vision, double vision, eye pain, redness, or tearing. Patient denies any hearing loss or denies any current tinnitus, denies any nasal congestion or sinus pain pressure, denies sore throat, hoarseness, or any difficulty swallowing. Neck, patient states decreased range of motion and pain with extension, flexion, and lateral movement. Patient denies any swelling. Respiratory, denies any cough, wheezing, or difficulty breathing. Cardiovascular, denies chest pain, palpitations, or shortness of breath with exertion. Neurological, denies any headaches, dizziness, focal numbness, or weakness. States shooting pain down the arm. Musculoskeletal, the only complaint is the neck, right shoulder with occasional shooting pains down his arm. Integumentary, no rashes or lesions, denies any bruising. Psychiatric, denies any depression, anxiety, however states he's tired of being in pain and is not sleeping well. Vital signs are all stable, temp 36.6, pulse 101, slightly tachy, most likely due to pain. Respiratory rates 18 with a blood pressure 128/84 and O2 sat of 96. Again, 8 out of 10 on a 10-point scale. 72 kilograms, 165 centimeters with a BMI of 26.48. With respect to labs, radiology, and other pertinent studies, at this time, those are foregone. Diagnosis based on solely a physical examination, which reveals constitutional, alert, and oriented, a well-nourished appearance of mild distress due to pain. HEENT, PERLA, extraocular motions intact, normal conjunctiva, normal cephalic, no evidence of hearing loss, moist oral mucosa, no scleral icterus, no sinus tenderness. Neck, patient has postural changes with head tilt, reduced cervical range of motion, and paraspinal muscle tenderness. Respiratory is cleared oscillation bilateral through the bases and no evidence of labored breathing. Cardiovascular, slightly tachy rate, but regular rhythm, no murmurs, gallops, or edema, equal pulses, bilateral upper extremities. Abdomen is unremarkable, soft, non-tender, non-distended, normal bowel tones with audible tympanic resonance, no masses, no right flank pain, no epigastric or pain on palpation. Musculoskeletal, patient has a positive right upper limb tension test, reproducible pain in arm with neck movement. Integumentary, skin's warm, dry, and pink, neurologic awake, alert, and able to move all extremities. Differentials included cervical radiculopathy, cervical spondylosis, and thoracic outlet syndrome. However, the last two were negated and going with a diagnosis of cervical radiculopathy given the patient's history of neck pain with radiating symptoms down the arm occasionally, and these are consistent with cervical radiculopathy. According to a recent article, this condition is commonly caused by nerve root compression, often due to disc herniation, degenerative changes, or osteophyte formation. So pain management is going to be ibuprofen 600 milligrams every 4 to 6 hours. In addition to that, we are going to add a cyclobenzaprine 10 milligrams every 8 hours as needed for muscle spasms and pain. Going with a multimodal pain management, we're also adding topical lidocaine 5% patches. And then supportive care is going to be rest, avoiding activities that exacerbate the pain or risk further injury. Educating the patient based on just kind of the process and what to look out for with respect to further inflammation and nerve compression. We educated the patient about the typical course of recovery and the role of conservative measures and healing. So the signs of complications were educated as well to the patient, discussing increased pain, difficulty breathing, numbness, weakness, tingling in extremities. And follow-up, we've asked the patient to schedule a 2-week follow-up to monitor progress, pain levels, and any potential complications. Imaging, again, was withheld based on current recommendations from the Journal of Orthopedic and Sports Physical Therapy. And reevaluation may include moving to an MRI, which would be the gold standard for diagnosing nerve impingement or nerve involvement. Additional evaluations for referral specialist care considered referring to a pain specialist if there's any evidence of significant complications or if conservative management is not effective. All right, thank you.